Hello everyone, I'm Dr. Dan Mikeska and I'm going to be talking about medical exercise in your fitness business. Before I get started, I wanted to give a quick update on some things that I've been looking into. I think based on the audience, particularly in the age of COVID-19, we can all agree that chronic disease is a serious issue. I recently wrote an article about COVID and chronic disease. And while doing this research, I found out that almost 25% of patients hospitalized with COVID have also been diagnosed with cardiovascular complications, contributing to almost 40% of all COVID deaths. Many of these COVID patients have also been diagnosed with mild inflammation of the heart muscles, which should concern patients with comorbidities. There's also evidence suggesting patients who have uncontrolled or untreated hypertension have a very high risk for becoming severely ill with COVID and developing disease-related complications. And for our obese clients, it's now known the risk for developing severe disease from COVID-19 increases as BMI increases. And people with a BMI of 45 or higher have a 100% greater chance of requiring mechanical ventilation and a 61% greater chance of death when compared to people with a healthy BMI. Based on this info, I don't think it surprises anyone watching this that exercise has literally been a lifesaver during the past year. So enough about the present. Let's discuss the past for a few minutes. I didn't start out in fitness. I started out as a martial arts instructor, which I still enjoy today. But when looking at the demographics, martial arts students are 18 to 34-year-old males for the most part. See how young I am here? They're just getting started out in life, new jobs, new homes, families, etc. Versus clinical exercise clients who are usually well established and realize that they've been sitting for too long, or never took care of that old college injury, or just saw their doctor and found out they're pre-diabetic, hypertension, overweight, whatever. As a business move, it was a good one, and I started networking with physicians, chiropractors, and physical therapists. The ones who knew me referred their clients. The ones who did not wanted to know why I was qualified to help their patients. That's actually a really valid question. So I went back to school. And during this time, I found out there is a lack of credible educational opportunities for fitness professionals who want to work with clients who have one or more chronic disease. Not to say there are not certifications out there, but the ones I looked into were heavy on the medical side and light on the fitness side, or relied on the facility having expensive testing equipment versus what most trainers have access to, or in some cases, if they required a college degree, they would not accept online degrees, which actually left me out. Understanding that I could not be the only one in this situation, or who thought about this dilemma, when I graduated with my doctorate, I developed the clinical exercise course. If we were in person, I would ask everyone who has clients with chronic disease to raise your hand, or stand up, or do push-ups, or jumping jacks, or something. I guess you could still do that if you wanted. Because of the deleterious effects of chronic disease and the importance of regular exercise, prior to COVID, over 8 million people were using the services of a personal trainer. Did you know by offering personal training services, you are implying that you have the knowledge, skills, and abilities, KSAs, to provide a safe workout? And a basic personal training certification suggests the holder is only qualified to work with apparently healthy clients. Realistically, when the overweight and obesity rate is close to 70%, close to 100 million Americans have high blood pressure, and over 10% of the US population has diabetes, it's very possible you are already working with a client who has a chronic disease. So it's not surprising in one recent survey, a large percentage of surveyed personal trainers indicated they have worked with clients who have one or more chronic conditions, which is outside their scope of practice. If a personal trainer provides orthopedic rehab advice to a client who comes in with a sore shoulder from golf or tennis, if you provide nutritional advice to the client who wants to get their summer beach body, or if you massage a client who complains of tight hamstrings or traps, without relevant training that provides a course of study and a comprehensive exam, you are most likely working outside your scope of practice. Because fitness is the front line of healthcare, there is a need for qualified fitness professionals who know how exercise affects clients with one or more chronic disease. So let's first take a look at what chronic disease is. Chronic disease is defined as a disease that progresses slowly, lasts a year or more, requires ongoing medical care, and interferes with activities of daily living, versus acute disease, which comes about and dissipates quickly. Most chronic diseases are caused by a few risk behaviors, such as smoking, poor nutrition, excessive alcohol consumption, and a lack of physical activity. Whereas historically, infection was a leading cause of death in the United States, today most people in the US will die from chronic disease. And I think you're going to find these following statistics fairly alarming. Chronic disease accounts for almost 70% of all deaths in the US. At least 50% and maybe as many as 60% of the adult US population has at least one chronic disease. And 25 to 40% of the US adult population have two or more chronic diseases. Type 2 diabetes affects over 30 million adults in the US and is expected to increase to 336 million adults worldwide within the next 10 years. Almost 40% of US adults are considered obese. The most prevalent chronic disease by far is cardiovascular disease, which is responsible for almost 18 million deaths annually and 30% of deaths worldwide, 31% of deaths worldwide. Hypertension affects over 100 million US adults. In the United States, it's thought that everyone over the age of 60, which is almost 70 million people, has at least one joint affected by osteoarthritis. Almost 2 million people in the US are diagnosed with cancer annually, and over 600,000 will die from it, making it the second leading cause of death. The prevalence of asthma has increased over the past few decades to just under 10% of the US population. And as I mentioned earlier, in today's world, we do have COVID. Anyone at any age with cancer, chronic kidney disease, COPD, cardiovascular disease, a weakened immune system, anyone who's obese, has type 2 diabetes, well, and the list goes on and on. They all have a greater risk for developing complications from COVID-19. But we know physical activity can positively affect over 30 chronic conditions, making it the #1 deterrent of chronic disease in primary and secondary prevention. Yet only 20% of US adults meet the minimum guidelines for physical activity. And 1/3 of the world's population does not perform the recommended amount of daily activity, making it one of the biggest public health threats of modern times. Physical inactivity is activity at a level less than what is required for optimal health, and is considered a cause of chronic disease and premature death. The deleterious effects of inactivity are progressive and compounding, resulting in a worsening state of disease and/or dysfunction. Cardiovascular disease, muscular atrophy, hypertension, lipid disorders, diabetes, osteoporosis will all deteriorate with prolonged periods of inactivity. Now we come to the root of the problem, and that is clinical exercise in the healthcare continuum, or the lack of. The current model of healthcare in the United States is based on treatment rather than prevention. Treatment is given for a disease or injury that has been diagnosed, whereas prevention is taking measures to avoid or improve a probable or possible disease or injury. Reaction versus proactive. Prevention is categorized as primary, secondary, or tertiary. The goal of primary prevention is to stop a condition before it starts, and includes immunizations, targeted types of exercise, and wellness programs and education. Secondary prevention interrupts the progression of disease in hopes of slowing down or reversing the progression. Examples include treatment for hypertension, asthma, and some cancer treatments. The goal of tertiary prevention is to manage and treat symptomatic disease in the hopes of reducing the severity, restoring function, and reducing disease-related complications, and includes measures such as treatment for late-stage cancer, emphysema, and some forms of rehabilitation. The #1 deterrent of chronic disease is physical activity for primary and secondary prevention. Therefore, the main goal of clinical exercise in the healthcare continuum is to prevent the onset of chronic disease. The second goal is to take our clients from functional to healthy to fit, and if they want, to performance. The role of a clinical exercise specialist is to work with the client's team of other healthcare providers, rather than trying to correct all of these issues on their own. Building this medical network and a willingness to refer clients to another provider indicates the fitness professional's main goal is the well-being of the client. The team of providers may include a nutritionist or dietitian, a rehab specialist or physical therapist, a mind-body specialist such as yoga, tai chi, or Pilates, or an alternative healthcare provider such as massage therapist or chiropractor. And the client referring physician may be a primary care provider, cardiologist, oncologist, orthopedist, whatever. Regardless, the physician is the center of the client's healthcare team and should be provided regular updates as to the client's progress. My absolute quote is by a guy who lived over, my absolute favorite quote is by a guy who lived over 2,000 years ago. Hippocrates suggested illness was caused in part by a lack of exercise. The healthcare continuum, known as an integrated system of care that guides and tracks patients over time through a comprehensive array of health services spanning all levels of intensity of care, has been largely ignored in the United States, as evidenced by the prevalence of preventable chronic disease. Even though exercise is an effective treatment for many chronic conditions, physicians often fail to promote activity as a means to prevent and treat chronic disease. In fact, only 1 in 3 adults is advised by a physician to increase physical activity. Because of its ability to prevent and manage chronic disease, clinical exercise, particularly as primary prevention, should be used to the same or greater extent as other prevention strategies, such as prescription medication. But who should be doing this? Well, because of their credibility, physicians are well positioned to promote clinical exercise. It's known patients who receive prescriptive exercise and community referral from a primary care physician are more likely to achieve a moderate level of activity for the recommended 90 to 150 minutes per week versus patients who receive usual care, which is also one good reason to network with physicians. One thought is training physicians to become fitness experts, and it may encourage them to prescribe and oversee physical activity. But given the demands and constraints on medical school curricula and a physician's time, a more prudent approach is to educate fitness professionals, us, in the prevention and management of chronic disease through clinical exercise programs. Because of a lack of education in exercise prescription and programming, only a small percentage of physicians are confident designing an exercise plan. In fact, in a recent survey of deans and directors of medical school programs, only 6% of med schools provided information on exercise testing and prescription, and only 10% were confident graduates of their programs could design an exercise plan. In contrast, us, fitness professionals, kinesiologists, are specialists who study human movement and its effect on health and quality of life. Accordingly, fitness professionals who are educated in exercise programming and clinical exercise are better prepared to design and implement medical fitness programs. But physicians do not feel confident referring their patients to a personal trainer. A physician has at a minimum a decade of education. Many personal trainers only have a weekend certification, and in some cases, none at all. A physician is a licensed healthcare provider who had to pass a board exam and is regulated by a state health department. We all know personal training has very little oversight and very few regulations. Many personal trainers work outside their scope of practice and beyond their level of education, placing their clients and business at risk. Physicians who are already prime targets for lawsuits are really hesitant to network with a trainer who does not possess the knowledge, skills, and abilities proven by a credible course of study and a comprehensive examination. And this is a good place to discuss some of the more common chronic diseases and give you a little preview of what you'll learn from the clinical exercise course. The first chronic disease I want to discuss is high blood pressure or hypertension. Because it affects over 160 million US adults and nearly 1 billion individuals worldwide, most likely you probably already have a client that does have hypertension, and they may not know it. Hypertension is an independent risk factor for coronary artery disease, stroke, renal failure, heart failure, atrial fibrillation, valvular disease, sudden cardiac death, cardiomyopathy, and aortic aneurysms. Accordingly, and not surprisingly, the higher the blood pressure, the greater the risk for a cardiovascular event, kidney failure, or stroke. Hypertension is the most common chronic disease risk factor, adults over 50 years of age have close to a 90% chance of developing hypertension. It is the costliest risk factor for cardiovascular disease. It is also the most preventable. Up until recently, hypertension was characterized by blood pressure of equal to or greater than 140/90, and pre-hypertension started at 120/80. Unfortunately, not many patients were taking their diagnosis of pre-hypertension seriously. So a few years ago, the metrics were changed. The new guidelines still consider below 120/80 as normal, but now 120 to 129/80 is considered elevated. 130 to 130 to 80/89 is now considered hypertension stage 1. Hypertension stage 2 is 140/90 or higher. Also, higher than 180/120 should be considered a health crisis, and the client should seek immediate medical attention. Primary hypertension, sometimes referred to as essential or idiopathic hypertension, accounts for 95% of all hypertension cases where the cause is unknown, or there is no known secondary cause. It usually occurs gradually over time and can often go undetected for years. Secondary hypertension has a known underlying cause and can be attributed to obesity, insulin resistance, high alcohol consumption, aging, sedentary lifestyle, stress, high sodium consumption, low daily fiber consumption, or lack of potassium or calcium. These risks can be identified independently, but they are often found in combinations. It is important for a trainer to know the medications a client is prescribed, as many common medications used to treat hypertension have side effects and may also affect exercise performance. Use, mechanisms, and side effects of common hypertension medications are listed here. And here are the thick guidelines for hypertension. I'll leave this up for a minute. So due to a reduction in peripheral vascular resistance, exercise training and a high level of fitness are associated with lower levels of hypertension. It has been estimated for a 10% weight gain, there's a 6.5 point increase in systolic blood pressure. For adults with hypertension, aerobic exercise training lowers blood pressure 5 to 7 points, while resistance training lowers blood pressure 2 to 3 points. Due to post-exercise hypotension, it is recommended clients with hypertension perform aerobic exercise on most days of the week, with an intensity of 40 to 60% of heart rate reserve, or an RPE of 11 to 13. Because of the deleterious effects of weight on blood pressure, clients should work toward an expenditure of 2,000 calories per week, with a focus on aerobic exercise. And because aerobic training lowers blood pressure to a greater extent than resistance training should be used as an adjunct to aerobic training and performed 2 to 3 days per week, at an intensity of 60 to 80% of 1 rep max. Also, a combination of light weights and fast pace may provide better training effects, so high intensity interval training should also be considered. And here is a list of cautions and contraindications, and I'll leave this here so you can look it over. But in addition to what's listed here, keep in mind it is possible in clients with hypertension that an increase in atrial blood pressure may dislodge arterial plaque, causing a myocardial infarction or a stroke. Further, any existing endothelial damage may be exacerbated. Because of a reduction in skin blood flow, clients with hypertension may not be able to dissipate heat effectively, disrupting normal thermal regulation. Therefore, exercise loads need to be carefully monitored and modified, or even ended at the first sign of heat stress. Also keep in mind, beta blockers blunt the normal heart rate response, nullifying the recommendation of 40 to 60% of heart rate reserve, and the RPE scale will have to be used to gauge exercise intensity. And here are some nutritional considerations. Although specific meal planning is the responsibility of a registered dietitian, nutrition basics can be discussed, and they may affect some aspects of exercise. This list provides general guidelines for clients who do suffer from hypertension. Keep in mind, it is outside the scope of practice of a trainer to provide nutrition counseling. The next chronic disease I want to discuss is diabetes, and it affects over 30 million individuals in the U.S., can be directly attributed to almost 80,000 deaths annually and indirectly to over 250,000. It is the 7th leading cause of death in the United States, with an estimated cost of almost $250 billion annually. There are over 1.5 million new cases reported every year, and over 84 million U.S. adults are considered pre-diabetic. Risk factors include smoking, obesity and excessive weight, sedentary lifestyle, high blood pressure and cholesterol. Cardiovascular disease is a major complication associated with diabetes, affects close to 1.5 million adults, and includes ischemic heart disease and stroke. Other complications include lower limb amputation, which affects over 100,000 adults. Diabetic ketoacidosis affects almost 170,000 adults. Abnormal protein metabolism, retinopathy, or neuropathy. The incidence of type 1 diabetes is only 5 to 10% of total diabetics, leaving the remaining 90 to 95% as type 2 diabetics. Diabetes occurs when there is a disruption in the production of insulin, resulting in hyperglycemia or increased blood glucose. Type 1 diabetes is considered an autoimmune disease in which the pancreas is damaged and does not produce insulin, whereas with type 2 diabetes, the pancreas does produce insulin, but due to insulin resistance or the lack of sensitivity to insulin in adipose tissue, the liver or muscle cells, it cannot produce enough, resulting in an absolute or a relative lack of insulin. There are a number of tests available to determine a diagnosis of diabetes. The A1C test measures your average blood glucose for the previous 60 to 90 days. The fasting plasma glucose test checks your fasting blood glucose levels, as the name implies. The oral glucose tolerance test tests blood glucose levels over a 4-hour period, and the random plasma glucose test checks blood glucose levels at any time of the day. Only a physician can determine a diagnosis of diabetes, and testing should take place in a healthcare facility with properly trained clinicians. And the table here lists the criteria for the diagnosis of diabetes based on the results from the various testing formats. So now let's discuss some treatment strategies. For type 1 diabetics, exercise is not considered an effective means to control blood glucose levels. However, because many patients with type 1 diabetes are often sedentary, overweight or obese, have hypertension or dyslipidemia, it is important for type 1 diabetics to maintain a regular exercise schedule. Additionally, because cardiovascular disease is the leading cause of morbidity and mortality in type 1 diabetics, regular exercise can help alleviate or lower the risk of cardiometabolic disease. For type 2 diabetics, exercise can be used in addition to proper nutrition and medication to improve insulin sensitivity and lower A1C. Other benefits include lower blood pressure and cholesterol, weight maintenance or weight loss, increased energy, improved circulation, and decreased insulin resistance. It is recommended diabetic clients be active 5 to 7 days per week, beginning with 20 minutes per day that can be split into shorter sessions, and progressing to 60 minutes per day using a combination of aerobic and resistance training. High-intensity interval training can also be used as a means to promote skeletal muscle oxidative capacity, insulin sensitivity, and glycemic control for clients with type 2 diabetes, and will not hinder glycemic control for clients with type 1 diabetes. Keep in mind, many metabolic conditions such as diabetes occur in conjunction with other chronic conditions such as hypertension and cardiovascular disease and pulmonary disorders, and the FIC guidelines for comorbid conditions need to be individually considered. There are a number of medications for diabetes that can help with control of diabetic symptoms. Because of the way they work, hypoglycemia is a common occurrence for diabetics, particularly during exercise. Type 1 diabetics do not have a uniform response to exercise. Therefore, determining a dose-response relationship to exercise can be difficult, and exercise may cause a hypoglycemic event. While exercise is known to decrease blood glucose levels, resistance training has been known to lessen the risk of exercise-induced hypoglycemia. To reduce the chance of experiencing exercise-induced hypoglycemia for type 1 diabetics, it is recommended resistance exercise be performed prior to aerobic exercise. For type 2 diabetics, exercise can result in lowering blood glucose levels, and the more physical activity that is performed, the lower the insulin resistance and the greater the insulin sensitivity. Additionally, type 2 diabetics can also suffer from abnormal insulin secretion, and coupled with exercise may result in hyperinsulinemia, instigating a hypoglycemic event. Continuous glucose monitoring can help determine a hypoglycemic event, allowing appropriate actions to be taken. And here's a list of some common diabetes medications as well as side effects and exercise considerations. Lifestyle intervention is critical to mitigate the consequences of diabetes, as well as prevent, delay, or reverse the onset of comorbidities. For prediabetes, it is suggesting a reduction of 5 to 7% of body weight combined with the recommended amount of exercise can decrease the progression to type 2 diabetes by almost 60%. A trainer needs to be aware of any dietary restrictions or modifications, as they can have an effect on exercise performance. Please be aware that everyone with prediabetes or diabetes should consult a registered dietitian. Weight loss should be the main goal based on energy restriction, low-fat diets, and increased physical activity. Diets should be low glycemic and high, and high in fiber. Vegan diets can moderate the effects of diabetes by up to 43%. Diets should include low-fat dairy foods, leafy green vegetables, and starchy carbohydrates such as rice, beans, and potatoes. Red meats, animal fats, processed products, refined sugar except during severe hypoglycemic episodes, fried foods, and salt should be avoided. Plant sterols and stanols may benefit blood lipid profiles, and vitamins A, C, E, or carotene may also be helpful. Microvascular or neural disease are common complications associated with diabetes, and even though regular exercise may prevent or delay their onset, it is prudent to be aware of neuropathy, retinopathy, and nephropathy. Neuropathy is weakness, numbness, and pain from nerve damage, usually in the hands and feet. If a client has been diagnosed with neuropathy, to mitigate skeletal muscular injuries, particularly in the extremities, avoid vigorous exercise such as plyometrics, and accordingly incorporating non-weight-bearing exercises may be prudent. Cardiac autonomic neuropathy can exacerbate cardiovascular disorders in diabetics, including a blunted heart rate response and sudden variations in orthostatic blood pressure. Using the RPE scale to determine intensity may be necessary, and sudden postural or directional changes should be avoided. Clients with diabetes have a high risk for retinopathy or retinal detachment. Clients diagnosed with retinopathy should avoid high-intensity exercise and limit systolic blood pressure to 20 to 30 points above resting. Nephropathy or kidney damage is experienced by 30% of diabetics, and the result is increased as blood pressure increases. The risk is increased as blood pressure increases. Clients with nephropathy can benefit from low-intensity exercise and should limit systolic blood pressure to no more than 180/200. High-intensity weight training that may induce the Valsalva maneuver should also be avoided. For most diabetics, the benefits of exercise outweigh the involved risks, but a trainer should be aware of the precautions listed here, and I will leave this up for a moment before we go on to the next segment. For the last part of this presentation, I want to touch on the business side for a minute. Although money may not be the main reason to become a fitness professional, it is needed. And not too long after opening up my business, I realized keeping track of clients was pretty important. After all, the goal of business is to consistently gain new clients, retain current clients, and regain clients who have left the practice. When working alone, it's easy to keep track of the how and why and when a client leaves. However, when there are multiple employees, procedures to document client turnover can be invaluable in determining the cause and effect. Tracking the time and reasons clients leave training services can provide information valuable to recruiting, retention, and regaining clients. To recruit, retain, or regain as many clients as possible, customers, the clients, and their expectations of service need to be identified, and a system to improve service and measure success needs to be implemented. But first, the customers and stakeholders need to be determined. In fitness, the customers are personal training clients, or if you have a membership base, they're the members. The stakeholders are the personal trainers themselves, the facility managers and owners, and to a large degree, the certifying organizations. Once the clients and stakeholders are identified, the expectations of each need to be determined. Clients expect a safe and effective workout. Trainers and facility managers and owners expect increased revenue based on an increase in the number of personal training sessions provided. And certifying organizations expect trainers to represent their brand in an honest and forthcoming manner. The methods used to improve services need to be based on the expectations of the clients and stakeholders. Clients need to know what services a trainer is qualified to offer. Trainers should provide a brief resume, doesn't have to be in writing, verbal is good, but it details their knowledge, skills, and abilities and their scope of practice based on credible courses of study and comprehensive examinations. So a prospective client can make an informed decision to employ or dismiss the trainer's services. New client assessments can also aid in determining if the trainer meets the needs of the client. The information obtained from a physical activity risk stratification form, a health history, and the movement assessment can be used to match a client with a trainer who possesses the KSAs to provide the client a safe and effective workout. When a client cannot be matched with a trainer due to an impairment or dysfunction discovered during the assessment process, it is important the trainer and the facility offer the client a referral to a healthcare professional who can help the client overcome an identified health concern or dysfunction. This very simple act of goodwill indicates the client's health and well-being have been placed above profits and will provide exponential future returns. For a return on referral to be realized, a network of other healthcare providers must be established. A discussion of interprofessional collaboration and an example network is provided in the introductory chapter of the clinical exercise program. And an outline of this process is actually located at the end of this chapter, and I'll show that a little bit later. The obvious metric in business is revenue. For personal training, revenue equates to the number of sessions trained, and the number of sessions trained is determined by the number of retained clients. However, client turnover is not often tracked. To understand why and when a client separates from a trainer or facility, it's important to measure at what point in the assessment or training process a client no longer desires services or is referred to a clinician. If a majority of clients leave or are referred out in the introduction and assessment process, an examination of how new clients are recruited should be considered. If clients are being referred out after a number of training sessions, training protocols and assessment tools actually need to be examined. This also provides an opportunity to review the KSAs and scope of practice to ensure that they are being maintained and accurately presented. After a referral and clinical intervention, tracking how many clients return to training can be indicative of the trust of the client and the effectiveness of a referral network. A number of tools to improve service quality are available, and depending on the need, the tool can be simple or complex and can determine how effective a process is by identifying gaps and opportunities. However, a check sheet, it's a simple tool for collecting data on process and can be used starting at the time of client engagement. A check sheet can record events or problems as they occur with the objective to identify frequency, patterns, and process deficits. Additionally, a check sheet can be easily implemented and revised and will provide continuous data. After the process for an introduction and assessment has been implemented, based on the criteria listed or determined to improve service, a check sheet can be developed to provide a simple means to determine at what point in the process clients leave. The items for the check sheet will be based on the needs of clients, such as goals, and the results of assessments such as a physical activity risk stratification, health history, and movement screen, and also the KSAs of the trainer. For a facility with a large number of trainers and clients, a check sheet for each day may be needed. For a smaller facility, a weekly sheet may suffice, and for a small studio or a single person operation, a monthly check sheet may be enough. A second check sheet can help determine why clients leave after employing the services of a trainer or facility for a period of time. Example criteria for the second check sheet are how long a client has been training with the trainer or in the facility, the phase and mode of the training, the equipment used, and if the client is being referred to a network provider for whatever reason. The check sheets, as well as the introduction and assessment process, are living documents that need to be updated as areas of improvement are identified. The check sheets and the associated metrics are important to determine if new clients present with conditions or limitations beyond a trainer's scope of practice, and to determine if a trainer is staying within their scope of practice for the existing clients. And here's an example outline for quality improvement. As business grows and the need for clinical exercise expands, trainers need to ensure they maintain their scope of practice boundaries afforded by their certifications. Knowing the needs and expectations of customers and stakeholders can allow a process to improve service to be developed and implemented while ensuring scope of practice is maintained. Check sheets are a simple method to provide quantitative data that measures client attrition due to medical conditions or injury. Data on referrals in and out of the business can also provide a measurement of the level of trust in a trainer's KSAs by clients and network providers. Additionally, having solid data on why a client quit training can have a tremendous positive effect on attracting future clients, retaining current clients, and regaining past clients. Up until now, very few organizations are trying to address the problem. Not physicians, not public health departments, or even educational institutions. Fitness is the real front line of healthcare. And as a clinical exercise specialist, you will understand the effect of exercise and activity on health and chronic disease. Know the role of fitness professionals in the healthcare continuum and recognize the signs and symptoms of common chronic diseases. You will be on the front line of healthcare by aiding in the management and prevention of chronic disease. You can position yourself as an essential part of the healthcare and business community and expand your scope of practice to the largest, fastest growing demographic in the United States. You will gain credibility and be able to network with other healthcare providers. And to top it off, you will earn 2 years worth of valuable continuing education credits, as this course has been approved by ACE, NASM, AFA, and NESTA for continuing ed. Lastly, you will increase income by expanding service offerings in an area that is much needed but severely lacking qualified people. Position yourself as an essential part of the healthcare and business community and gain credibility with other healthcare providers by becoming a clinical exercise specialist. And lastly, please don't forget to pick up a copy of the textbook available on Amazon. Thanks for listening today.